Peter and Ian, thank you very much for the invitation to join this fantastic meeting. So I'm going to start with the basics. I'm going to briefly cover a wide range of endoscopic procedures, particularly with regards to statistics. Other speakers through the day will, I'm sure, as Marianne has already done, focus in much more detail. So a bit about general definitions and procedure-specific complications related to the types of procedures that we all recognise. I would like to start with an apology, and that is that I'm not sure that I know what I'm talking about, which is not a very good start. But do we really understand and agree what we mean by an endoscopic complication? I think we'd all agree with this. Yes, a post-polypectomy bleed or a perforation, that's a complication. Post-ERCP pancreatitis, we've spoken about. A perforation related to a colonic stent, yes, certainly. What about some other things? What about a perforation at the time of ESD? You know, skilled endoscopists close that perforation at the time. Is that even a complication? Parabiliary contrast during an ERCP. It's something that as an ERCPist we see, we often rather discount it, should we, in all cases. But what about other things? The poorly tolerated upper GI endoscopy. We dismiss that. We don't record that as a complication. For the patient, that may be an absolutely fundamental episode in their lives. And I'll show a little bit of data around that. What about something that in the UK is a subject of real focus now, which is post-colonoscopy colorectal cancer? The patient has a perfectly safe, perfectly well-performed colonoscopy, has no immediate complication at all, and a cancer is missed. Now, for the patient, that may have life-defining implications, and it is as a result, whatever the explanation, it is as a result of a colonoscopy which is said to have, with the aim of excluding a cancer or a significant lesion, has excluded that, but the patient is subsequently, in a short time frame, found to have that. Is that a complication? So anyway, I went to the dictionaries and I wanted to look up, well, what is a complication? And I'm not going to go through these in detail, but they didn't help me terribly much. A complication is a problem or difficulty that makes a situation harder to deal with. Maybe, although, we recognize that in ERCP, one can do a perfectly straightforward procedure that isn't hard to deal with at all. It's only in the aftermath of the pancreatitis that the problems commence. I don't know, does this work? An unexpected event related to endoscopy, which impacts on the patient's immediate or long-term pathway of care. In other words, it affects what we do immediately during the procedure, but for the patient, it may also affect what we do subsequently. There's a few caveats getting on to data related to complications. Most published data is from specialist centres. We recognise that. There are increasingly good population-based studies, but a lot of the, certainly initial data comes from specialist centres, often retrospective. Few people advertise their complications, and that's why we often don't hear about them, and that's why a meeting like this is so fantastic. We have an expression in the UK, you may also in Germany, that you should not air your dirty laundry in public. And none of us we like to advertise our successes in endoscopy, not our failures. And in fact, there is so much to learn from those failures and problems. Next question is, are all complications visible? I find this paper really interesting. So this is looking at patients having ERCP under conscious sedation. Now, I'm aware that in Germany, that is done much less than it is elsewhere. These are the patients just having midazolam and fentanyl. This paper led by Peter Siersema. 10% of patients after a sedated ERCP met criteria for moderate to severe mental health problems. I think that is absolutely fundamental. Is that a complication? We might not say so, but for the patient, it definitely is. So let's get on to the slightly more boring hard data. Okay, so we're going to start with diagnostic endoscopy. The first thing to say is that diagnostic endoscopy is incredibly safe. We know that. But the great majority of complications that do occur are cardiorespiratory. Okay, they're related to aspiration, hypoventilation. They are much more common in those with comorbidity, and we know about that. The patient with obstructive sleep apnea, morbid obesity, etc. And these are patients who really should be triaged to alternative means of sedation, including anesthetic involvement. It really is only when one gets to therapy that the complications really arise. And these are not all the therapies that, of course, one does in endoscopy. We recognize that stricture dilatation, whether for benign or malignant strictures or in terms of dilatation, achalasia, carries an increased risk of perforation. PEG placement, percutaneous gastrostomy is very commonly performed procedure. Often in many units, it is the middle grade doctors who are doing those. All the clever, sexy ESDs are being done by the super specialists. But in fact, for complex reasons, including, of course, the patient's comorbidity, PEGs carry a high reported complication rate. Yes, perforation, yes, bleeding, two complications that are very difficult to do much about at the time. If you hit a vessel on puncture, it's very difficult to avoid that at the time. We know that there was a 15% 30-day mortality related to PEG. Now, what we always say, I think fairly, is that yes, but that largely relates to the morbidity of the patient. But nevertheless, there is a definite PEG-related mortality. When one gets into polyp and lesion removal, we know that polypectomy in the upper GI tract carries a significantly higher rate of complications, particularly bleeding, compared with within the colon. And again, once we move into EMR and ESD and others, specialists in this area may be talking about this later, there is another quantum leap in complications. With respect to gastroduodenal ESD, I think this is an interesting observation by Paspatis that over 50% of patients having gastroduodenal ESD will have evidence of pneumoperitoneum. Again, I think it's fair to say that that is not viewed as a complication unless there is a subsequent clinical problem. I'm not going to say a lot about small bowel, except to say that this is a safe procedure. The complication rate mirrors that of upper GI. New procedures, spiral enteroscopy. It'll be interesting to hear people's views on the complications related to that. There are a few perforations reported related to torsion. Is that more of a problem than we otherwise, the anecdote might suggest? Pancreatitis is interesting. Pancreatitis seems particularly to be associated with small bowel enteroscopy, whether that's because of trauma in the region of the pancreas or possibly ischemia. I think nobody is quite clear. ERCP-related complications. Traditionally, ERCP has been the procedure that carries the greatest complications. Marianne has said a few words about this for now. Again, when one thinks about pancreatitis, big range of pancreatitis rates, that relates to two things. How we report pancreatitis. If one says, well, any patient who's got a bit of bellyache after the procedure and an amylase more than 3 times the upper limits of normal has got pancreatitis, well, you will certainly, if that's your criteria, you will capture patients or diagnose patients of pancreatitis who perhaps do not truly have that. But also patient and procedure-specific factors are hugely important with respect to pancreatitis. We know about perforation and bleeding. Cholangitis, the undrained biliary tree is certainly much more at risk of cholangitis. In the early days of cholangioscopy, we showed a significant step up in the rate of cholangitis before we were giving routine antibiotics to everybody having a cholangioscopy. There is a mortality. Show of hands, who consents the patient for death having an ERCP? Okay, so it's interesting. Who does not? Yes, so more don't than do. Interesting, Mike Wallace in the States, I'm aware that it's standard to consent for any complication that is greater than 1 in 10,000. Well, I'm sorry, the mortality rate related to ERCP is near as damn it 1 in 1,000 or 1 in 2,000. We like to forget that. We like not to tell our patients about it, but it is the reality. What about miscellaneous causes? This is a bit of a hodgepodge, but these are problems that we now see that we didn't see before. For example, stent migration, proximal pancreatic stent migration. We never got referrals for this 10 years ago, and now because people are putting in prophylactic pancreatic stents, we're being asked to deal with the stent that actually it hasn't migrated, it's been deployed halfway up the pancreatic duct. So these are new complications. Other new complications, air embolus or even CO2 embolus. This relates to cholangioscopy, almost always related to the use of air insufflating or CO2 insufflating ultra-thin gastroscopes. That can, of course, be a fatal complication. I'm not going to say anything about duodenoscope-related infection, but it's a real thing, and it's exercising engineers right across the world now to see what can be done about that. I'm not going to say anything about grading of ERCP-related complications. These slides can be available to you afterwards, except to say that we recognize that grading the severity of all endoscopy-related complications is absolutely fundamental. Again, when we consent our patients for complications, it's no good just saying to the patient, there is a 3% risk of ERCP pancreatitis. We need to understand and tailor the complication rate according to the patient in front of us and the procedure. Now, none of us should now any longer be doing ERCPs in young females with a normal bile duct and suspected sphincter of Oddi dysfunction type 3. But if we do, those patients have a massively increased pre-procedure predicted pancreatitis rate. Perforation, again, nice grading system. And this is data from the very well-kept Swedish National Endoscopy Database. Over 50,000 ERCPs, nearly a 1% rate of significant ERCP-related perforation. I was surprised to see that more than 30% in their series were distal bile duct injuries, wire perforations. I don't know whether some of those patients are actually, in effect, retroperitoneal bleeds related to sphincterotomy, which would normally be the bulk of these patients. Again, getting back to the point of are all complications seen at the time? This is a patient, young man, who was referred to us. He had an uncovered mesh metal stent put in 4 years earlier for presumed malignancy, which he did not have. He now comes back with biliary obstruction, and this is his cholangioscopy. And I say this chap's in jail. He's now got tissue ingrowth up at the liver hilum that is obstructing his biliary tree. And the decision to put in an uncovered stent 4 years earlier will be life-defining for this young man. He will end up with a liver transplant if he gets to that. And so the procedurist, the endoscopist 4 years earlier, did a beautiful, perfect, uncomplicated ERCP that relieved his jaundice, and it was a disaster. Colonoscopy, again, brief run through on this. Large data now acquiring. Colonoscopy, diagnostic colonoscopy is a very, very safe procedure. We know about the risks of perforation. Perforation can occur, of course, with diagnostic and therapeutic. Bleeding is very strongly geared towards polypectomy. We rarely see splenic rupture, and post-polypectomy syndrome is seen particularly in patients undergoing ESD. Again, there are good stratification criteria for the severity of bleeding post-colonoscopy, and I won't, for pressure of time, go through this. I think the story around colonic ESD, I don't do ESD, but I think, again, it's a very good example of you have to see who is providing the statistics and what that means for your practice. So this is a nice study looking at both Asian and non-Asian experience in colonic ESD. And if you're consenting your patients, you need to take this into account. It's not enough just to give a blanket complication rate, because certainly this is a generalization, but if you're doing ESD in Japan, your complication rate for colonic ESD is going to be different, both in terms of perforation and delayed bleeding, to that in the rest of the world. Does that relate to experience? Yes, probably. So here's a case I had a few weeks ago. 49-year-old lady, very fit and well, had a post-menopausal iron deficiency anemia. No GI symptoms whatever. Had a straightforward colonoscopy, minimal sedation, chatted to me the whole way through the procedure. And to my surprise, there are a few of these. This was on coming back from the cecum. She was perfectly well. That was all right. So, question for the audience: what is the endoscopic diagnosis? Very good. Very good. Cat scratch syndrome. And it looks more like tiger scratch than cat scratch, but yes, absolutely. Okay, next question. What's the underlying diagnosis? Sorry? Oh, told you. So I found that very interesting, because this patient had no symptoms whatever to suggest collagenous colitis, and yet biopsies confirmed that. Okay, is this a complication? She's all right, isn't she? She's fine. Interesting observation. That's all good. Except I get called by the nurses to say she's got a bit of abdominal pain 20 minutes later in endoscopy in the recovery area. Thought, nah, okay. Tummy was soft. I lost my nerve. I did a CT scan, and she had intramural air throughout the left and right colon, or from the transverse colon right round to the cecum, and she also had pockets of intraperitoneal air. So she's had a perforation. Now, we kept her in hospital for 5 days. We did repeat imaging. She didn't need surgery. She was fine. But I was rather horrified, I have to say, to have a colonoscopy-related perforation in those circumstances. Just a couple of words about colonic stents. Again, just the theme of we need to be careful where the data's come from. Colonic stents, lots of retrospective data since the late 1980s showing very safe, 1% perforation rates related to stents, until people started doing proper randomized studies. And the Dutch group led by Janine van Hoof did a couple of studies which really stopped us short. Because their studies, well-done studies, showed much higher rates of perforation than we were expecting. Now, there's criticism of the studies because lots of hospitals doing very small numbers, which may have had a factor, but they were looking both at early perforations and late perforations. And again, as part of the decision-making process, they found high rates of late perforations in patients having colonic stents who subsequently went on to Avastin-type anti-angiogenesis chemotherapy. A couple of words about EUS. EUS, diagnostic EUS, very safe, including with FNA. Very low reported perforation rates. for diagnostic EUS. I have to say that many people would feel that the larger linear therapeutic echoendoscopes, are associated with a slight uptick in perforation, but pancreatitis and infection very low. Again, just a couple of words about therapeutic EUS. This is where the complications come online. Lots of amazing advances, but with it, of course, come complications. There had been concern, remains concern about, although lumen-opposing metal stents are a great advance in the management of pancreatic pseudocysts, walled-off necrosis, concern about high rates of bleeding and buried bumper syndrome. This probably is going to be lower than was reported a couple of years ago, having moved to earlier removal of these stents less than 4 weeks after insertion. And again, biliary access, one always needs to compare the complication rate of a new procedure with what the alternatives are. And there's quite good evidence that these new techniques, compared with percutaneous transhepatic drains or percutaneous gallbladder drains, are going to find a role, but they are not without complications. So finally, we've talked a bit about statistics. I'm no good on statistics, but what I do know is we need to understand whose statistics. So here's a question. I'm assuming, being in Hamburg, there's some football enthusiasts. So what percentage of penalties have been missed in World Cup final shootouts? Give you a choice. 20, 12. Oh, shoo, and you're Welsh and don't know anything about football at all. Come on. Yeah. Okay, 20. Okay, very, very good. All right. So 20%. 20% of penalties have been missed in World Cup shootouts. All right. But again, a bit like our endoscopic complications, it is of no relevance what the complication rate is, the statistic is, the chance of missing a penalty is. What you want to know as a German supporter is, what's the chance of your team missing a penalty in a World Cup shootout? Okay? So, what's the answer? Okay, well, the answer is 6%. Okay? Anyway, I'm an English fan. I don't care I do care how good the Germans are actually at penalties, but anyway, that's another story. But what about as an English fan? Well, it's 40%. So, a silly point, but I hope it does make the point that when we think about complications, we have to be reflecting back on what our complications are. That's the only information that is of use to the patient. Do we record and do we reflect on our own practice with regards to complications? And one of the reasons why a meeting like this is so fantastic is that it gives the opportunity to share our complications, because ultimately that's the only way that we learn and perhaps reduce the risk to others in the future. Mariana's mentioned ESG days. There's going to be some great live endoscopy, I hope without too many complications, but please join us. Thanks so much.
So thank you very much, George. This was very comprehensive, so I think your kids should consult you more often, but you haven't left much for the subsequent speakers. For the sake of time, maybe one or two burning questions. If that's not the case, I think there might be more discussion for the more specific topics. Just one tip, so you don't have to do, you can take photographs, but you don't have to, because we have a live stream on the Endoscopy campus, where the whole meeting will stay on, as well as I think on the GI complication website, and then we will archive the different lectures so you could look at them specifically during your morning bus ride or whatsoever. Yeah, one surgical question, or question from the surgeon.
Thank you for your presentation. As I heard, there is no internationally consented definition of endoscopic complications or grading. I want just to give you an example of the surgery. In the surgery, we have now a very internationally consented complication grading definition. It's the Clavier-Dindo definition. And in most papers that you read today, you find this definition. It's recognized quite worldwide. The other thing is we have created a group for the surgeons who do esophageal and gastric surgery, and we have found in the literature 20 different definitions of anastomotic insufficiency. 20 different definitions. So we sat together in a working group for several years and established a registry, and this is based on clear definitions with grading. So there are lots of, about 100 items, and this is now used in the scene of the centers, the international centers for esophageal and gastric surgery, and we have 4,000 cases now of esophagectomy with clearly registered complications, defined and graded. And so we can compare the centers. And this would, of course, be very good for endoscopic complications also.
Yeah, absolutely. I think Todd Barron's got a question. I completely agree with that. For the procedure-specific complications such as ELCP, as I discussed, there are grading systems, but particularly with regards to the outcome of those complications, such as the severity of ELCP-related pancreatitis.
So, in the ASG published in 2010, a lexicon for adverse events. Cotton was the lead author. And there's a chart in there. I was part of that study paper when we got together. So we actually did grade severity of complications for perforation, bleeding, infection, et cetera, as mild, moderate, severe, and then of course death, which is the most severe. So there's 2 points there. One is it hasn't been, I guess, obviously widely accepted or integrated, but we made an attempt based on some of the surgical literature to do the same types of things for grading of severity. But the other is I wonder why everybody hasn't moved to the term adverse event rather than complication, because I think it is a better sort of term than the complications. So thank you.
You want to answer this?
Yeah, I think it's a fair comment that absolutely that adverse event incorporates more than a rather more restricted terminology of complications. I wouldn't like to suggest that Peter has to change the name of his fantastic course, though.